I'm not the house of cards that falls down easily. I'm strong enough to handle what you throw at me.
Welcome to Mental Health News Radio. I'm your host, Kristin Sunanta Walker. Just what are we going to discuss? The intimacy that is mental health. Let's continue to make it as comfortable as discussing brain health or heart health. This show has been on the air for several years, and we have amazing co-hosts. And then we created a network of podcasters on mentalhealthnewsradionetwork.com, a place where every possible facet of mental well-being can be talked about openly. My show, after several hundred interviews, the format is this: intimate, deep, funny, touching, sometimes uncomfortable, but always vulnerable conversations with interesting people. The goal is to have you, our listening family, many of you who have become my good friends, feel as though you are listening in on private conversations. Thank you for tuning in and becoming part of this amazing journey with me, and now with our network of podcasters. Just knowing this podcast might be helping any of you realize you are not alone on this journey called being a human being makes doing this podcast worth every second.
After all we promised, we'd be cordial.
Hi, everyone. Kristin Sunanta Walker here. We're going to do a little bit of a twist on a show. It'll be for mental health business and also about some other things that we're going to talk about with my guest, Roy Alabado. Roy, thank you so much for coming on the show.
Hi, thank you.
So tell our listeners a little bit about your background in mental health.
My name's Dr. Roy Alabado, and I have been in the business in managed care, working at a company in Philadelphia called Community Behavioral Health. And it began in 1997, and the genesis of the company started from Estelle Richmond, and it basically was a managed care, a behavioral health system that was for Medicaid and Medicare.
Okay, so you've been there that long?
No, I mean, I was there for about 10 years, but it was very interesting in terms of how it was started and the services that they provided and how inventive the company was as well.
Okay, well, let's talk about that, because usually we don't use terms like inventive when it comes to mental health organizations, especially managed care. That's a high compliment. So
Right.
Give our listeners an idea what you mean by that.
Well, I thought it was inventive because it was a managed care system that worked with the provider network in Philadelphia. And it provided services. First thing, it's not perfect, right? Mm-hmm. So it helped the quality of the providers within the network. It also provided a gap where services were needed within the system, from children's services to case management. It developed a system for, high recidivism, clients coming in constantly through the ERs. It helped manage the money because fee-for-service is running out. And so it managed the money a lot better than the government would have done. Yeah, it's not perfect, but it was good for that system at that point. Yeah.
Right. And I remember when, we started dealing with things like, managed care organizations in the state of North Carolina, as an example. And there was a huge uproar. I mean, there were people, counselors fighting with each other, not fist fighting, obviously, but verbally fighting with each other at conferences about how awful this was, and, all these things going back and forth. It was a stressful time. So it sounds like you guys or that organization, when it came to, the MCOs.
Yeah, at some point you have to manage it because, the money's going to be running out. And also, too, it's, the providers were just charging and charging and charging, and it just needed to be managed a lot more efficiently, right? So it was costly to the taxpayers, as well as, the quality of service, access to service, So all these elements where the company was made in it kind of helped the environment a lot better, meaning the provider network, the relationship between the insurance and the provider, and also to the consumers.
One of the things that interested me about speaking with you is that, I'll hear things from different people that work as an employee of a treatment center, an addiction treatment center, as an example. And it's always, we don't get paid enough.
Yes.
They don't care about treatment. It's but a bunch of number crunching. And I always think, because I know, from being in the business side of mental health, it's not that black and white. So I wanted to, have this discussion with you because I'd like to help. Yes, there are things that are wrong, of course, but it doesn't help when you are so one-sided about something and you don't see the cost of every little thing. As an example, someone will complain, well, they just cut my pay, or they send me home, and 5 minutes before it was, oh, I've been watching Netflix movies and on Facebook all day at work. And I'm thinking to myself, well, they're paying your salary or your hourly rate, and if they don't have enough patience to warrant you being there, because they don't have enough people coming in, and so you have all this time to be on Facebook and watch Netflix, then they can't, it's going to cut into patient care and the cost of patient care to keep you on salary when there's nothing for you to do. So I'm always like, let's look at the other side of these things too.
Yeah. So physical health and behavioral health or mental health is a lot different. The big trend right now with physical health is really price transparency, the term price transparency, where, when you go to a doctor, right, hospital A, and you get a total knee, a TKR, total knee replacement, one hospital might charge you $17,000. And if you go to hospital B, another hospital might charge you $61,000. So there's a disparity, right? There's a gap in price. And so with insurance, whether depending on what type of insurance you have, the insurance pays for the price of what they want to pay. And then the consumer or the patient is left to pay for the difference, right? So now what has happened is that the government has kind of initiated this kind of like price. It's a price list of different prices for different types of services. Mm-hmm. It's better for the consumer, right? But in some way, the consumer is also kind of stuck because they are only obligated or positioned to go to a particular network.
Right.
It's a very complex system, right? So you have the consumer, the insurance company, and then also to the provider network who's providing the service. So, and that's why it's just, it really lands on the consumer, where it's the quality of service, the how expensive it is. It's catastrophic, where these prices are just ridiculous. And then, it's just one hit at a hospital and you're totally broke, right?
Right.
On average, as a single person, it's about $11,000 a year, about $10,000 to $11,000, not just even hitting a service, meaning you're paying premiums and you have to, make it up to your deductible, and for an individual. And then for a family, it's about 20 grand, right? Not even having services. So, having premiums and also to your deductible. So it's quite expensive. And then it's left for the consumer, if any services were provided, that the consumer is responsible sometimes for the difference. So now this price transparency has left us to at least understand how much is this going to cost.
Right.
There's a secrecy between these hospitals and these providers about pricing, because we don't really talk about it. You don't know. You just got to get the service done.
Right, exactly.
So that's really kind of like this conversation that we're having, and help people understand about how, just a broad lens of how managed care works related to the consumer and then also to the provider.
So in terms of, I understand how, it's different. What does it look like then in terms of mental health services or addiction treatment services, as opposed to what you just described for physical health?
So behavioral health is kind of like the stepdaughter,
Yeah.
right? So,
Yep.
So the services, access to service at times, you can't get an outpatient therapy appointment until like maybe 3 weeks after you've gotten out. Marginalized groups have also had a lower quality of service because of dictation. Insurance usually dictates where you go, right? And also to the services that are provided in terms of, so we dealt with access, the quality, and the service, I would say. There's a gap in service. There's a gap in service. Yeah, there's a gap in service.
That's why, for example, someone can come in, even getting an appointment to have an assessment with the psychiatrist, as an example, can take 3 months. And that's if you know somewhat of the system.
That's right.
And then getting your first appointment after that initial visit, where it's just an assessment, can take another several months.
That's right. And the psychiatrist might have a larger copay than your physical health, right? And based on that, the medication.
Exactly. We'll get into that too. But let's go back to that piece where people have a lack of understanding around what all goes into the other side, the managed care side, the ones that are accused of not caring because all they care about is counting dollars. How do you've worked on that side. So how do you answer that or have a piece of that conversation when you're talking with someone who's never worked on that side? They've worked on the treatment side and they have no understanding of how the money flows, why things are charged the way they are, how insurance pays, how, what goes into running a business, all of that stuff. They have no idea, but they're making these, these judgments. How do you take part in those kind of conversations?
So, we have monthly meetings with various providers. Let me just give you an example. So there's, it's termed the Crisis Response Center, where there are designated hospitals within the city of Philadelphia where people can go to get treated and assessed, right, for a psychiatric evaluation. So we have high utilization consumers that come in, and it's a revolving door. One comes in through Temple, was recommended a service, AMA's out of that service, goes to University of Penn, comes in, gets evaluated, a recommendation was done, right? And the client AMA's out or relapses. It's just a revolving door, and it's costing taxpayers so much money.
Right.
So we decided to really, I thought it was great where it's based on medical necessity. So there's criteria, right? And based on that, and based on history, and based on current issues, and based on, the current mental status, right? It was a very specific assessment and presentation for the client and the managed care to decide what specific treatment was deemed medically appropriate at the least restrictive manner, based on the history and based on the current issues and et cetera. And we decided a lot of innovative things. So, for instance, they developed a 23-hour bed, which was an observation, and clients came in. They were assessed, they were pre-certed, they were evaluated, and they had, a urine drug screen, so we knew what kind of drugs they were using. And we, instead of giving them a day, right, or a denial, we actually gave them a 23 observation bed, and they had to, reevaluate the client at a certain amount of hours and give us an update. And I thought it was inventive because the provider still got paid. They weren't denied. But then it was a better assessment in terms of finding, a more appropriate level of care. And so based on that, they were reassessed and they were, pre-certed again, reevaluated. And then we agreed on specific level of care. So I thought it was a win-win situation for both the provider and then the consumer, as well as also to the managed care organization.
Was part of your job explaining why things are done the way they are to people that worked in the industry that didn't have your view of things?
It's hard for someone to have your same perspective because you're on the other end, right?
Right.
But we laid guidelines. We had technical assistance, and eventually the provider system slowly kind of understood the same language, really.
Okay.
There were also other providers just didn't get it, right?
Right.
I always recommended a performance-based kind of like contract because, provider A, who always did the right things and followed the rules and XYZ, was still getting the same price as provider B, who was not up to their standards, right?
Right.
And that's where I kind of felt that, different providers should have a different rate based on their performance.
So give us an example of a provider A, the one that, is at standards or above standards. What kinds of things would they do to meet the standard?
Utilization review was up to par. Documentation, compliance, training, adequate staff providing services, limited, episodes of basically minimal problems with the provider. So,
okay. And when you're saying provider, you're talking about an agency, like an
agency,
outpatient mental
yeah.
health. Okay. You're not
Yes.
talking about providers in a single provider. Okay.
Yeah, like a certain group that was providing a service to a certain population.
So in determining, so I know in some states it got to a point where funding that went to specific providers was funneling through the MCOs, and MCOs, some of them would cut certain providers
Yes,
from that list
that's right.
and only go to other, and it was this big outcry. And I also thought, well, are those agencies meeting the guidelines? Is that maybe why they're getting funding cut?
Yeah. Some of them didn't survive because they were hiring the wrong people. They weren't doing what they were supposed to do. There was fraud involved. So they just didn't meet the part, and they didn't survive. So, but within a city, every provider is important because we need them.
Right.
We need them within the city, but if they weren't, meeting the standards, then they were let go or we work with them.
Right.
Yeah.
Right. So I guess what I want, listeners that are listening from that business side to understand, it isn't just this, it's unfair. It's this government thing that's just coming and slashing because treatment for people. And there's always something deeper to look at in these situations.
Yeah. I mean, there always is. And, providers can get innovative and, try to cut corners as well. And, they do things in order to survive, really,
Right. The margins are already slim.
Yeah. The provider network doesn't pay as much, right, compared to physical health, and they're surviving. So they've gotten innovative by providing other services within the gap that's not provided within the population. There was a service called wraparound services.
Right, I remember,
behavioral health services. And it was like these interventions within the environment, within the school system, within the home, And some of them were services that were just being misused because, the school district wasn't providing the adequate education. And so this particular student needed help or assistance, right? Or sometimes, it's the family that doesn't really want to take care of their own child. So they need behavioral health services.
Right.
So within the assessment, that needs to really kind of sometimes we just look at the current symptoms rather than the underlying issues,
How deep did the MCO that you were with, how deep did they get into working with electronic healthcare record systems?
The EMR.
Yeah.
So I thought it was great because at that time we worked within the network, and we actually had, for instance, a specific coding system where clients were coded, especially high recidivism clients that were going in as a revolving door, right? And we targeted those clients because we needed to case manage them a lot better. The presenting issues were basically very similar. And we hired these really intensive case managers that really knew the case. For a initial client that presented like that, it's like, wow, we would give them like so many days of psychiatric help, right? Inpatient. But for these clients that are constantly revolving, these same presenting issues were very, very common, and they were similar. And these intensive case managers just knew the case, and then they were kind of like, they helped propel basically an appropriate level of care. I mean, these clients are being assessed, but they help guide the client into a better level of care and a better treatment at the least restrictive manner.
What would you say is the difference now that you can see from, when you first started? Obviously there's a lot, but a big difference between how MCOs are working now as opposed to, when you were first working for one.
I think they got more savvy based on evidence. So it's a lot more, treatment is based on data. So they're using a lot of data more, the highs and lows of the year, number of inpatient, the level of care. So they've gotten more data, and by working with that, understand the data, and then based on that, provide a better outcome for patient care.
Okay, well, that's good. Do you think there's more understanding and less resistance between the providers and the MCOs?
There's always still
Always some.
Yeah. There's always, I always say, conflict is two different belief systems. So I'm just defining it that way, right?
Right.
So one thinks one differently and one thinks the other. So that's why there's a conflict.
Mm-hmm. Did you ever have people on staff, I know this wasn't their official title, that were sort of the therapist or mediator, the people that could speak both languages, and they sort of were the ones that would go in and say, okay, I hear what you're saying, provider, I hear what you're saying, MCO, and they were able to just keep the peace, and because they could speak both languages? And is that kind of what you did?
No, I mean, I worked in a lot of different settings. So I did utilization review. I worked in the hotline, the psych hotline, right? So, so I would work during the day, and I was a children's specialist. And then at night, I would come in on a Friday sometimes and work overtime, and then work the crisis line. So I enjoyed working the crisis line. So I would work the night on a Friday night once a month, and get to hear all the presentations, voluminous different presentations of why someone needs drug and alcohol and behavioral health services. Yeah. One thing that the company also had was it had a member service. And I think this is one innovative way where it was a part of a department where a group of people actually, they didn't talk to providers, they talked to clients. They were like liaisons, talking to clients to help them understand more, get access to services, that kind of stuff. They were like liaisons, case managers, you know. I thought that was very inventive for the department to develop, just to have communication with various people.
Gotcha.
Yeah.
Well, tell our listeners, just so they understand too, your educational background. So what is the doctor about?
So, I have a master's. I went undergrad at Westchester University, and I have a Bachelor of Science in gerontology and communication. And then I went to St. Joe's University for a health administration and health education degree. And then eventually I decided to get a Doctorate of Education in educational leadership. So it was just, I enjoyed healthcare and I enjoyed education. So it kind of married together, and I'm in both. I currently work for Jefferson Health, New Jersey, as a consultant in their clinical education department. I'm a college professor at the Rowan College of South Jersey, and also do part-time work for a behavioral health, a drug and alcohol outpatient in New Jersey as well.
Gotcha. So you're steeped in the healthcare field.
I am.
Good. We need people like you steeped in the healthcare field.
It's at least you understand the dynamics of different organizations,
right.
And if you can
Right.
have a lens and and then talk about it, it's kind of welcoming to the public.
Well, as our final section, which is, I think, the fun, no tension part, tell us about this book that you're a part of.
So one of my loves in the world is to travel, and I'm a single dad, and I developed a couple years ago the idea to write a children's book about my son, Bronson, who was 3 at the time. He's 7, and I decided to write a book, a children's book about our lives. So the 3 pillars is about food and travel, about being a single parent and the ideals and challenges of being a single parent, because half the population are single parents.
Yep.
And last but not least, the art of parenthood. Just sharing about what it's like to really love your children. And I always say, what your children really need is 2 things: quality time and love. If you spend quality time with them and you love them, you're good as gold. So the book, it's going to be a series of books. It's called the Live Life Like Bronson series, my son Bronson. And the first book is about Miami dreaming. I got back from Miami Monday to just work on details about the launch there. And I'm really excited about it.
Fantastic. And tell our listeners again what the name of the book is.
So the first book is Live Life Like Bronson, Miami Dreaming. And you can get it at www.livelifelikebronson.com. And you can also get it on Amazon.
Fantastic. Well, thank you so much. You reached out to us, I know, through Joe Mitch, who does a great job with the podcast All in Recovery.
I love Joe Mitch. He is my friend, and he's also a little mentor, and I'm his mentor, so it's symbiotic. But
yeah,
Joe Mitch is a very insightful person. He's been an expert in the drug and alcohol field, and I love his show as well, All in Recovery. So
absolutely, and he's a wonderful human being on top of it.
There's another mentor that I also, his name is Dr. Josh Luke. He's out in California, and he wrote a couple of books as well with Acute and also to Health Wealth. And he's just also been another great mentor of mine.
What's the name of one of his books?
It's called Acute, EXACUTE, and Health Wealth.
Oh, that you gave me the names. Gotcha. I went right over my head.
Yeah. So he's also been a mentor of mine. So it's great to network with those kind of people.
Absolutely. People that really care, that like you obviously do. Well, thank you so much for coming on the show. And
Kristin, thank you. And
absolutely.
I look forward to seeing you soon.
Absolutely. Now, thank you, listeners, for tuning in to another episode of Mental Health News Radio.
Sometimes I'm passive aggressive, but never without good intentions. I heat up and act on my emotions.
Thanks so much for listening to Mental Health News Radio. Our podcast can be found on iTunes, Stitcher, and hundreds of other podcast apps, or you can visit our website at mentalhealthnewsradio.com. If you have a question or would like to be a guest, become a podcaster on our network, or join the amazing organizations that help keep us on the air, please email us at info@mhnrnetwork.com. Get ready for that special goodbye from our resident therapy dog, Miles, and a special thanks to Emily Sohn for letting us use her incredible song, Cordial, for our podcast music. Listen to the full song on SoundCloud at emily.sonne.
Don't be surprised when I don't hate on you. After all, we promised we'd be cordial. Sometimes in you I can fight it.
Good boy.